Right, morning again. So the question you all might be asking is, why are we doing this top topic at you guys' end of course? And I guess it's important that you recognize that obviously studying, and especially in medicine, is going to be a lifelong event. And the other aspect being, how well have your current study techniques helped you? Because I guess if they're doing well, everybody is getting A in all their classes. Now, normally when I do this face to face, I can ask people questions and to stick up their hands, etc. Well, we obviously can't do that, so I'm going to call out people's names and you just answer me. Um, because it has to be a little bit of interactive since I need to know where you guys are at. So let's let me start with Natasha Haber. Natasha, have you changed your study habits since high school?
Morning, doc. Changed, kind of, more like modified, I think.
All right. Tell me what you've modified. Yeah. How you've modified what you do.
Um, I've tried to modify then. Instead of waiting for the last minute to cram everything in, um, I guess I've tried to go through the material more than once and use videos and I guess um, write my own notes and stuff like that.
Okay. All right. Let me ask one of the guys. Chad Kong, how have you adjusted or have you not adjusted since high school?
Hi, morning. So instead of just reading the material, I like to discuss it with people now. So it's like it's a bit of interactive learning rather than just laying it off roles.
Sorry, I wasn't hearing you so well.
Can you hear me now?
Yeah, I'm hearing you.
I was saying instead of just reading material like what I did in high school, as it was so easy to learn then, I tried to discuss it with others to see if I'm lacking in areas.
Okay, so you kind of have a little study group sort of thing.
Yeah, a nice small group, so it's just not too distracting.
Okay, all right. Okay. Well, one of the things, anybody, I know you haven't had many ward rounds, but um, unfortunately, but I'm sure you all can remember at some point when you got embarrassed on a ward round or in a lecture. Is there anybody who didn't or has not had that experience? If you haven't, just tell me. Well, I guess everybody has had that experience. And can you specifically, is there anybody who can't specifically remember what the issues were in that period of embarrassment? All right. Okay. So let's talk a little bit about um, studying and what the aim is. One of the things that we've all done and we all tend to do is to, and I did it in my time, we took the books, we went to the library, and we went from page 10 to page 20. And that was our plan, but we usually woke up at the bottom of page 10. And we tried and we read it again, and then we got to page 12, and then we got stuck again. And so we've had this sort of rote situation where we're really just trying to attempt to put data into our brain and hoping that it's going to stick sometime. And so what we then do is we kind of repeat it, reread it, and put it in. However, you recognize that if you have an experiential situation, whether it's happy, sad, angry, whatever it is, that is kind of like vaccines. It tends to stick in your memory, and so you conjugate the data with an emotion, an event, and your memory actually pulls it back. And there are people who will tell me they remember things 10 years later from a lecture, something I said in a lecture. It obviously resonated with them. And so when we in fact are studying and we're doing what everybody has told me they're doing data entry. So you're putting a lot of data in to your brain, but you're not necessarily conjugated with any experience. If anything, what you're conjugating it with is that I'm bored, I'm tired. Why do I need to do this? But the exams are coming up, so I need to do it. So we're not really conjugating that data with any significant emotional response. So one of the things we need to do is be curious, and that's the emotional thing that I'm recommending, is to be actually curious in terms of where you go in terms of your study. So if we pick a topic, and we say we're picking a topic, say nephrotic syndrome, rather than going to the chapter on nephrotic syndrome, the first thing we do is ask ourselves some questions. Just as though we came from Mars. We had no clue what nephrotic syndrome is, so we say, well, what's nephrotic syndrome? If I had a patient with nephrotic syndrome, what would they look like? What would they come and present with nephrotic syndrome? Okay. So I'm asking myself, how do I see this patient with nephrotic syndrome? I may then ask another question. Are there any unique biological or biochemical features that are associated with nephrotic syndrome? And what are those biochemical features? So I say, yeah, there's proteinuria, there's hyperalbuminemia, etc. Okay? And so I'm asking these questions. These are the biochemical features. And I might then ask myself, the next question is, well, what's causing this nephrotic syndrome? And I can ask myself what's causing it from two aspects. What's the etiology? In other words, has there been some process that's triggered the biochemical changes I'm seeing? So maybe I had a post-strep, or I had a strep infection that led me to a nephrotic syndrome, or I didn't have anything noticeable that triggered it, so I may be a minimal change nephrotic syndrome. And therefore, okay, so that there are things that may have triggered my nephrotic syndrome. It may have been lupus or something like that, or it may have been a drug. But then what's actually happening in my kidneys that's giving me the proteinuria? So when you ask, you're now asking these questions, and I say, well, where is the lesion in my kidney? Is it in my tubules? Is it in my glomerulus? And if wherever it is, what's happening at that level that's causing me to leak protein in my urine? And then I then say, well, okay, I now know what's happening at the kidney. I then ask myself, so what can I do about it? And what are the therapeutic modalities that I can do? So in maybe 5 or 6 questions that you have asked, you could cover nephrotic syndrome. And you will then now go to the chapter with a focus to actually answer the questions. And so the next morning when you come on ward rounds and somebody asks you, well, what is the what's happening at the glomerular level in patients with nephrotic syndrome? You have sorted, you've seen that question before, you've researched it, and you can answer it. And the other point it does is it actually allows you to stay awake while you're researching the question. So rather than falling asleep on the bottom of page 10, you now have a focus where you are now actually quite interested in answering the questions that you have put to yourselves. And these questions are the same questions you're going to get asked in exams. That's going to come up on an MCQ, etc. And you have focused your study on the questions, and therefore you have focused it on answering those questions rather than just reading the 10 pages in the book of nephrotic syndrome. So what we've talked a little bit about is data entry. So you're putting data in to your brain and you're actually trying to get something stuck with it, some emotion, maybe curiosity, interest, stuck with that. And you therefore are hoping to pull it back out associated with that emotional remembrance. But when we look at the data output side of things, Chad is kind of doing it a little bit with his study group, but how many people are doing data output? The first time you're trying to retrieve the data in a lot of situations is when you're asked a question on the ward, or when you're sitting in the exams with the question, and that's the first time you're actually saying, well, let me pull this data out, which I have put in, and I put it in maybe at least 4 times, and God knows why I can't remember it. But you can't remember it because you haven't practiced data output. When you guys go to a movie and watch the movie stars and people acting in a movie, they have rehearsed the scene 5, 10, 15, 20 times. How many times are you guys rehearsing the data that you have put in? And that rehearsal can be done in a number of forms. Chad does it with a small, non-distractible study group, and that's okay. All right, so you are now challenging each other to come up with the answers for stuff that you have already read. Okay, so study groups are a good thing to help you pull and establish pathways of data retrieval. The other aspect of is just writing an essay. Ask yourself a question and say, how much of what I read do I now know? Okay. So let me just put the question down, write out what I think I know the answers are, and then recheck it. Okay. But we have to, in fact, practice doing the actual retrieval of that information. You can't be trying to retrieve it for the first time in the exam. All right. So that's important. So if I can get you to do something is look at how you in fact input your data. And the second aspect is develop techniques with your groups, with yourselves, as how you can actually practice that data retrieval. Now, the other aspect of attempting to actually keep information in your memory is also by interacting with patients. Medicine remains an apprenticeship system. Back in the 18th and 1900s, to become a doctor, you kind of stuck around with a doctor for 10 to 15 years, and then you went on and had your own practice. It's still experiential, and therefore patients that hopefully you will get to see sooner or later in this pandemic. Patients are a great tool in helping you to remember pathology. And so when you take your histories and you do your examination, it's not just so the fact that, and we say, well, we need you to have 3 histories submitted or whatever it is. It's about the learning process that you get from each patient. Histories are also the most important tool and the first step in making diagnoses. So taking histories is really also about experiencing the presentation of various disease states in your patient. And so doing your history, and I always say this to students, you can't take a history about a subject you don't know. So if you have a patient who's presenting to you with hematuria, and you don't know the different causes of hematuria, then your history is going to be a secretarial history where you're just writing down what the patient tells you, versus an investigative history where you're asking probing questions which are related to the different causes of hematuria. All right? So your history is actually an important part of putting together what you have read in a real life setting. So I've read about nephrotic syndrome. However, how does what I've read interact with what the patient, or conform with what the patient actually has? Okay? So when you've done your histories, then you've got to correlate them with your reading on the subject. Okay? The other important aspect of cementing disease processes and conditions is through your clinical examination and getting to know the patient who has the condition. So you end up in an OSCE exam with a little girl with hematuria, and you remember Shauna K, who was on the ward at Spanish Town, who had hematuria. And because you had correlated your reading with Shauna K, then your case becomes very easy, because you've had that real life experiential relationship with Shauna K and all the issues that she had, versus just reading something on a page 365, paragraph 4, and you're trying to remember that. Trust me, you don't remember it very well, but you're going to remember it a lot better when you've correlated that that page with a real life patient. Okay. The clinical examination is also important. And as you do your clinical exam, you are reinforcing the findings that you read about. And the other thing that you did was develop your clinical skills. So it's not just about studying what's in the book, it's about honing also your clinical skills. And it has to be hands on. As much as you can get right now, you've got to do your hands on. I say to patients, if you're examining say to students, if you're examining a patient's abdomen and you pick up the enlarged liver, but you miss the enlarged spleen, then your differential diagnosis will never include splenomegaly, and you're going to miss the condition. Okay? If you're listening to a patient cardiovascular system and you don't pick up that there's a S3 or an S4 with a gallop rhythm, then your diagnosis becomes different. So the process of studying here in medicine always has to involve, yes, your book and your YouTube. It also has to involve your practice at all levels. Data retrieval practice, data consolidation, with patient involvement in both history and physical examination. All right? And we still remain a scientific specialty. We're not history or literature. So there's still a scientific method in play where you've got data collection through your history and your physical examination. And then you have data analysis. So you're analyzing the information that you have gotten from your history and your physical examination to come up with a differential diagnosis. Okay? So all of these processes need to be incorporated as you go through your study. Okay? And at this point, I'll ask guys if there anybody has any questions, since I've been chatting nonstop. But I think, all right, no from a key. The point is, guys, as you've been through most of the medical program, you're a year away from finishing up. And your final year should really be pulling all the information that you've gotten through the previous 4 years and putting it all together. All right? So your anatomy, your pharmacology, your microbiology, okay, your pathology, your physiology, all come together in the patient. And so as you see a patient, and a lot of times I see students essentially, they really just want to go through the routines to get out of the program. But remember, guys, what you've got to do is, all this training is to help make accurate diagnoses in patients and to treat them appropriately based on the diagnosis. So this year really must include pulling everything together. Every patient you see is going to have some pathophysiologic basis of disease going on, right? A lot of in pediatrics, there's a lot of microbiology going on. You have a patient with a UTI. What are the organisms that are common in UTIs? Are certain organisms more common in boys and girls? We have lots of respiratory disease. What's the difference between, at the pathological level, between bronchopneumonia, bronchiolitis, lobar pneumonia? Do I understand that what the pathology is? And therefore, based on the pathology, what are my clinical findings going to be when I listen to the chest? And what are the likely organisms that are going to give me each of the different conditions? All right. So if I have a bronchiolitis, what are the organisms? Are they going to be the same organisms that are involved in a lobar pneumonia? So there's no case that you're going to come across that really is too simple. A kid with vomiting and diarrhea with gastroenteritis. What are the different organisms? Is it bacterial? Is it viral? Is it parasitic? What's the physiology behind the gastro that's actually giving me diarrhea? And am I having large volumes of diarrhea, which suggests small bowel disease? Or am I having small volumes, which could be colonic disease? So every patient is never too simple. Every patient that you see must be a segue into learning about that condition. So here we have your patient now. You went to the books, you read the books, and you took that to the patient, and the patient is then going to send you back to the books to confirm and to consolidate. Okay? So that's significantly important in really how you move forward in this final year. Really tying everything together that you've learned before. Pediatrics, we see orthopedics. We see patients with Blount's disease. We see patients with fractures, etc. So many times, everybody has done ENT, but when you ask about what are the landmarks involved in a acute otitis media versus a serous otitis media, right? You should now be pulling your ENT experience back into pediatrics, all right? And that's how you keep consolidating the information that you put together and also using it. So using that information is also part of the output learning that you need to do. All right. So it's not just practical. I mean, sorry, it's not just theory. It's practical. And we get people in OSCEs in a long case, and you can know those who have seen the patient and those who are trying to remember what was in the book again. I remember reading that chapter or something in the book. And then you know the candidates who, in fact, yeah, I've read the book, but I've also seen the patient and can correlate the two. Okay. Any other questions, comments? I see somebody putting in the chat. Let me look. Oh, no, that's just to tell me no questions. All right. All right, so I think I see you all next week, Wednesday, when we have a 2-hour session. And I let you all go back and have your breakfast now, there being no other comments.
Thank you, Doctor. Appreciate it.
My pleasure.
Thank you very much.
Thank you, Doc.